and welcome. My name is Meredith Richards, and I'm the Programs Librarian here at Pawtucket Public Library. So if any of you have any ideas, please come see me after the event. I'll be happy to listen and see if we can get something together. So this is a panel discussion, Rhode Island's healthcare landscape, and I'd like to introduce the moderator, Elizabeth Moreira, Public Health and Leader for the City of Pawtucket, and Director of Operations for Project Health CV Inc. Thank you.
Welcome everyone. Welcome to the audience who's here physically, but then to our audience virtually. We want to welcome you to the discussion on Rhode Island's healthcare landscape and the conversation about healthcare and hospitals post-COVID-19, and just some feedback from our experts, our honorable experts. I'll introduce our panelists today. Chris Koller, the president of Millbank Memorial Fund and Rhode Island's first health insurance commissioner and CEO of Neighborhood Health Plan of Rhode Island. Welcome, Chris. Thank you for being here. And I will welcome Dr. Michael Fine, colleague and great friend, family physician, author, chief health strategist for the City of Central Falls, and the former director of Rhode Island Department of Health. So thank you both for being here today. And I wanted to shake it up, wanted to start it up with a question that is buzzing in our community right now, I'd say, which is the Attorney General and the FTC, Federal Trade Commission, not approving the Care New England Lifespan merger. I wanted to get feedback from both of our panelists today, and I'll start with Chris Koller.
Thanks, Elizabeth, and also thanks to the library for hosting us, and for you folks who are coming out and folks who are watching online. I think it's going to be a fun conversation. Hopefully you're not just going to be listening to me and Michael, but we'll just talk about it together as a community. So I was not a fan of the merger, even though on the side I work a little bit for Brown University and they were one of the big supporters of it. But one thing that I feel like, in the job that I'm in right now, I'm with a foundation, and we talk about the health of populations, or population health, and I think we're in this, I think we do healthcare so that people can have long and healthy lifespans, and hopefully equal outcomes, so we care about equity. We want all people to have that. And my thing is that we actually know the things that can help people do that. A little bit of healthcare, a whole lot of education, some really good housing. Healthcare when people need it, that's important. But it's the things that actually aren't about delivering medical care that really matter. And so efforts to make our hospital industry grow really are not good for the goals that I think are important: lifespan, equity. And so when you're in a merger, when you're looking at a merger, that's really about having a bigger healthcare industry. It's about having more jobs and maybe better quality healthcare, but it's not about having longer lifespans for everybody. And there's a fair amount of evidence now, because we're not the only state in the country where people are talking about having hospital systems merge. Then there's a fair amount of evidence that when hospitals merge, costs go up and not much changes with lifespan and life expectancy. Maybe quality changes, but there's not a whole lot of effect on quality. And so I was kind of grateful for, frankly, that Attorney General Noronha and his staff, who worked really hard, just kind of stood up to it and said, you know, we're not going to buy. No one wants to stand in the way of something like this. You didn't see the legislative leaders, you didn't see the current governor, and they said, you know, I don't see a plan here. I don't see a way that this reduces costs, improves quality, or contributes to the bigger goal of lifespan and longer lifespan. It contributes to the goal of lifespan, but that's a capital of lifespan. So I was all for it, and I think part of the reason why we had this conversation is that then Michael, if I may call you Michael, and I wrote a little bit about it. We wrote an opinion piece in the Boston Globe that said, okay, now what? because we can recognize that Care New England in particular is in severe financial shape. You folks in Pawtucket know that because that's what drove the closure of Memorial Hospital. Are mergers inevitable? And the gist of our piece was no. We've got 1 million people. We can support healthcare here. We've got billions and billions of dollars that's spent on it, but we can't just trust that it will take care of itself. We have to understand and this is the gist of what Michael and I wrote. We have to actually understand what's going on with these important institutions. They have to make a commitment to us as the state and as communities, and we have to make a commitment to them, which is a very different idea than we're going to grow, we're going to do bioethics, we're going to do high tech and stuff like that. And so that's really what Michael and I were calling for is okay, health systems, you commit to Rhode Island, and we'll commit to you. And that means a different relationship with state government. It means a relationship maybe with Lifespan and Care New England that look a little bit more like what we have with Blue Cross or what we have with Neighborhood, where Neighborhood is like basically a ward of the state. It gets all its money from the state. Blue Cross has public appointees. They have to have their rates reviewed, their finances reviewed, and that's kind of a deal that we've got. And so that's a long-winded way of saying that's kind of what we're calling for here. Because we got to be in the business of helping people have long and happy lives. It's not just about the latest high-tech care, and that's really hard to say when our loved ones are sick. But that's kind of what we're all here for, is to help everyone live the best possible life possible. And it's about housing, that's about education, it's about neighborhoods. It's not about having the latest high-tech stuff. So.
Thank you, Chris. I would like to hear your opinion, Dr. Fine, on this merger
So,
not happening.
by disclosure, Chris and I are old friends, and we've been talking about this for 25 years. and so what you're going to hear is sort of an externalization of our usual argument, discussion.
It's what you hear when we walk along Pawtucket. That's what we talk about.
So I actually agree with Chris tremendously that what we ought to be about are equal life chances and healthier, happier lives. And I also agree with Chris that the way we get there is not by spending more money on health care or on health services. The way we get there is by spending more money on housing and education and public transportation and community centers. Community development and having people be able to be in communities together. And so when healthcare comes and cannibalizes the rest of our public services, as it has done generically over the last 40 years, you can look at graphs of what we spend on healthcare. The healthcare cost inflation is twice general inflation, or it was until the last year anyway, for 40 years. So we keep spending more and more on healthcare, less and less on public housing, less and less on public education, less and less on public transportation, and our health outcomes are good evidence that our current approach simply doesn't work. Life expectancy in the United States has been falling now for about 4 years. Our disparities based on race or location have gotten larger. We're just not doing as well as we ought to be doing, given that we're spending not only a lot of money, we actually spend twice as much as the average of other industrialized countries in the world, and we actually spend 60% more than countries that have the best health outcomes, the longest life expectancy, the lowest infant mortality, and stuff like that. Now, how do Chris and I agree and disagree on the merger itself? Well, we also agree that the merger application that the Attorney General rejected was, in my view, I'll say this gently, a lousy application. It didn't really say anything. It just said, let us do it and then we'll figure it out. And that was a huge disappointment, and particularly a disappointment to me, because I have to go on walks with Chris and defend this position. And the position that I have generally had is that a merger, not this merger, but a merger is actually a good thing for the state if we could do it right. And I come to that as a clinician. The strongest part of healthcare in Rhode Island, from my perspective, is the tunnel that connects Rhode Island Hospital and Women and Infants. The clinical collaborations that happen are really important in terms of what healthcare workers can and should do. We ought to be in the business of taking care of people and giving them what they need, not fighting over turf or who owns what. And the notion of a single entity that does the entire spectrum of care in a population of 1 million is a very attractive notion from a clinical perspective, because the more you do things clinically, the more expertise you get, the better you are at doing it. So particularly for highly specialized things, if you're going to do, and we don't do them here, but if you're going to do heart transplants, you need to do a lot of them. If you're going to do coronary artery bypass surgery, you're best when you do a lot of it. And 1 million people is enough to get you most things, and most things done well, but 500,000 here and 500,000 there may not be. So I had hoped for a merger, and the other piece is that from the perspective of training health professionals, having a single entity for clinical experience is a good thing, because it makes the whole clinical experience piece more coherent. And that's true of nursing schools, which I think are incredibly important, and we've under-resourced. It's true for a medical school, though I think we should have 2 medical schools. I think we need a public primary care medical school that takes kids or students from our communities and trains them in primary care and lets them go back to our communities. But that whole educational process is much more coherent when you have a single hospital entity that's focused not on how much money they're going to make, not on how much money their executives make, but on the public health outcomes that we need, on longevity and so forth. So from that perspective, I thought the idea of a merger had promise, but I also agree with Chris that every time we look at it, when you merge hospitals, the hospitals use their monopoly power and increase prices. And what we can't have is a merged entity that's trying to take more money away from education and housing and public transportation. Because that would be self-defeating. So, I have this belief, and I think Chris, I'll let him speak for himself, but I think he thinks it's a bit of a mystical belief, that if we combine a merger with a regulatory authority, that a hospital regulatory authority that set prices and really had some muscle to make sure the hospitals were focused on public outcomes, I think we would be better served. Something like the PUC, but for hospitals, I think is the way to get this done, though, I'll let Chris address that himself, but I understand that we as a state have not always been first to create transparency and governmental excellence. And so, one has to be concerned that might not work. But I also agree with Chris that we really, really need public accountability and public involvement in hospital boards and hospital governance if we're going to make sure that hospitals are directed to deal with the health of the population and the cost of healthcare. Because when you look at other countries that do this well do it for half of what we do it. And I think we should be challenging ourselves. Well, I'm not going to say get to half tomorrow, But I think in Rhode Island, we ought to challenge ourselves to get to 20% less than Boston, so that businesses locate here because of the economic impact of lower healthcare costs. But what this merger really unroofs, and this is what Chris and I also tried to get at in our op-ed, it unroofs a certain lack of leadership that we've had in Rhode Island about healthcare for many, many years. We've kind of let hospitals do their own thing, employ expensive lobbyists, and the expensive lobbyists get what they want. I'm not sure this particular merger is dead. I think you ought to keep your eyes open in June, that there might not be, I would be almost surprised if, at 2 o'clock in the morning, late in a legislative session, somebody introduces a bill that makes it possible or even necessary this thing goes forward. But that's the kind of approach to healthcare planning we've had. We don't sit down and think out how many hospitals we need. There's nobody in charge of making sure we have enough primary care doctors and have them in the right places to make sure that everybody can get a primary care appointment or a primary care doctor of their own. We know that in Pawtucket and Central Falls, only about 50% of people have a primary care doctor. And that sets us up for trouble because, and Chris has been a national leader in this, because primary care is the only medical service that's ever been shown to reduce cost and improve public health outcomes. So rather than spend a whole lot of time and money on hospitals, I'd much rather see us spend a whole lot of money on primary care, but nobody's in charge of making all that happen. And so the challenge for us when I think about this merger is how we have enough leadership and public involvement to make good choices and make them together. I love that you are all here. I think you guys are heroes for coming out to talk about this tonight. But we need, 200 people in a room, and we need 200 people in Warwick and in Coventry and even in Situate. And really have a real public discussion so that our legislators understand that they have some responsibilities in this regard, and our governor as well.
Great. Interesting perspectives on both ends. I knew this question would get the conversation going, and I hope there's questions coming up in the audience's mind as well, because I would love to hear from you. But just transitioning into the future of Care New England and what you'd like to see. I'll start with you, Dr. Flynn.
Well, if we don't have a merged entity, boy, that's a real hard one. I know I don't want to see Care New England be taken over by a for-profit. Our Hospital Conversion Act actually got written to prevent the acquisition of Roger Williams by the Hospital Corporation of America, I want to say in the 80s. But I think the track record of for-profits hasn't been great. And I don't want to see it taken over by a healthcare system from Boston and have our ability to control it taken over. So I think Chris's notion that the legislature and the governor in Rhode Island should be much more involved and steer it correctly and help to put it on a strong financial footing, to me seems really important. I'd love to see Care New England be the standard bearer for the development of primary care so that we have a primary care practice or health center for every single Rhode Island community. And they could do that, and if they did it well, we'd all be better off.
So I'll talk about Care New England. I want to get there. But remember, we had hospitals, and there are these big bricks and mortar things that the communities were very proud of. And then hospitals started to merge one hospital with another. and that made them a health system. So Care New England is this kind of odd combo of Kent and Butler, and then good old women and infants. And what has happened because of technology is actually most of Care New England's revenue now actually doesn't come from hospital stays, from inpatient stays. In most health systems, I don't know Care New England in particular, but in general, most health systems, what we think of as hospitals, make their money out of outpatient services. It's been an enormous change. They say they do it because of coordination, integration, but really it's to kind of feed the beast and follow the technology, because surgeries that used to be done indoors, inside are now done ambulatory, and we like that. So they just kind of follow the money, and that's what they've had to do. Where Michael and I differ, and this will come out in terms of Care New England a little bit, is I tend not to believe, and when he was health director, I was health insurance commissioner, we were getting fights about this, because I'm an incrementalist. I sort of take what we got, and what can we do to advance it a little bit? And I do that with Care New England. If we were going to play chess master, we might say, okay, Rhode Island Hospital and Women and Infants, you get together and you get the Academic Medical Center and knock yourselves out, and we'll try to do all the training and all this stuff. But we don't have that. We got Newport paired with Miriam, paired with Rhode Island Hospital, and we got this odd combo, and Bradley, and we got this odd combo over here. And I don't really want to try to unwind that stuff. Because I just think it's politically impractical. But you got to make your moves with an idea towards this long-term goal, the kind of things that Michael's talking about, community involvement, promoting primary care, which leads to Care New England's biggest issue right now is they don't get enough money for Medicaid. We've actually created Care New England's problem, because the bulk of Care New England's revenues, or a large part of their business, comes from maternity care, and they do a great job with it. My wife is nowhere near being pregnant, but if she were, she would want to have her baby at Care New England, at Women and Infants. But half of the births in Rhode Island now are paid for by Medicaid. And we have balanced our budgets in part by making sure that Medicaid pays providers as little as possible. So we've created the problem with Care New England, and I think we have to own up to it. But we got to get something for it. It can't be a bailout, and this is sort of this is where the leadership comes in, is that, okay, if we're going to find the money somewhere, and you would think with all this federal money sloshing around, we could do something with it to fix Care New England's Medicaid rates. What are you going to do for us? Is it going to be primary care? Is it going to be aging? Let's sort of figure that out. And from a government standpoint, legislators have to lead that conversation. That really, Michael and I tried to do it from the executive branch as health director, as health insurance commissioner, as Medicaid. And we got our hands slapped because the legislators would say, well, you're doing policy and that's our job. Well, okay, legislators, do your job. And this is a perfect example of it. And if they sort of look the other way, or sort of hold their nose, or hope that a Boston hospital system or a New Haven hospital system fails, shame on them. Because not all you have to do, but the key thing is to fix Care New England's Medicaid rates, and we ought to get something for that. And that's really what I mean when I say, okay, we got to have a deal here. You commit to us, and we'll commit to you.
I promise we'll transition from Care New England, but there's one more question. We're in the city of Pawtucket.
Yeah.
Consequences on the closure of Memorial Hospital. I'll start with Chris.
So you two could speak much more eloquently about that because of your jobs. What I would say is, don't tell anybody, but in part I'm responsible for the closing of Memorial, in the sense that I made it really hard for Blue Cross to pay health systems, where the health systems thought that they needed. So Care New England, I think, made an ill-advised purchase to get Memorial, and then they realized, oh my gosh, this is in bad shape, and they went to Blue Cross and they said, bail us out, and Blue Cross said, I can't, because we have limits on what we can pay. And so, but from a financial standpoint, from a capacity standpoint, we had more hospital beds than we needed in Rhode Island. they might have been in the wrong places, but we didn't need all the hospital beds that we had open. Now, I think, well, you guys can speak much more to the toll on Miriam for emergency rooms, to the toll on the availability of primary care and things like that. There's a toll in terms of just community pride, you know, and I drove up there today, guy has this empty building, you say, well, they're gonna put veterans housing in there or something like that, but it's tough. But I think we have to answer those questions if what we want is longer lifespan for all, because I'm just not sure that having Memorial has, or I'll put it in the negative, not having Memorial has decreased overall life expectancy in Pawtucket. But I would defer to the public health experts to say that.
So I was a resident of Memorial. I trained in Memorial. I walked around those floors at 3 o'clock in the morning for 3 years. And so I have fairly strong feelings about it. I don't know if any of you remember Jack Cunningham, but Dr. Cunningham was my mentor and teacher and friend. And he brought his practice to the family care center, and that made the residency in family medicine. And it let me be who I got to be today. And I loved being in that hospital. You know, you could get things done there way quicker and way more precisely than other places. So I missed it. At the same time, I know that Chris is right about the number of hospital beds, and I actually signed the Hospital Conversion Act application that let Care New England take over the hospital, because of the way the law was architected. I didn't have grounds to say no. If I had said anything else, the decision would not have stood from a legal perspective. But I also knew that this was already 2015, I think, probably 2014. The Memorial was already a dead hospital. It hadn't modernized in the right way. It wasn't thinking about new directions in healthcare. It hadn't competed effectively with Rhode Island and the Miriam. And so many people were making a different choice, which made it unsustainable. And let me tell you, I tried really hard to convince folks at Memorial to do it differently so that they would stay alive, but they had a way of doing it, and that was the way it was going to be. But that's all history now. You know, I think the largest impact has been on EMS in Pawtucket and Central Falls, which now have to make many more trips than they used to have to make. If I had it to do over again, I would strongly require that there be a system that allows people who don't need the hospital to be taken to a community health center instead of the hospital. But I tried hard to get that done, and you know, folks in Pawtucket were pretty good about trying it, but the health center wasn't ready for it. You know, but that's where, you know, we have a mess, not a system. Everybody gets to do their own thing, and nobody's thinking coherently about how we approach it. So I think it's been a burden on EMS. It's been a burden on both cities. It's hard on poor and working people who have a hard time, you know, getting to Rhode Island. You know, I know it's 7 miles away or something like that. In Rhode Island, would I say this? But, you know, like, you can't get here from there so easily, and you can't get there with one bus. So it's been a burden, and it's been hard, and the burden has fallen out unfairly, as most of our decisions fall out. But on the other hand, I can't think of a good way, and I can't think of a good way that we could have kept Memorial alive after a certain point, And it speaks to the absence of leadership in state health policy that goes back 40 years, because nobody should have ever let it get like that. It was abandoned, and just abandoned, and that was kind of a heartbreaker.
Well, I'm gonna pause a little to see if any audience members have any questions for us. I know sometimes when you start thinking about something, like, let them ask it before I forget it, so I'll have the audience, Suri?
I thought there was an article in the Journal this morning, an editorial, from, was it Senator De Palma, talking about incremental increases, that we should look at some of our healthcare costs, like Medicare, and look at them every so often and see if they need to be increased. And I think he mentioned some bills that he and someone else had put in the legislature, and I didn't know if you knew anything about them or had any thoughts.
Yes.
Go ahead.
Senator De Palma called me.
Right.
This is Rhode Island.
This is Rhode Island.
Yeah. No, because I do this stuff. We're in touch with other states. So what? I'll take a step back. I had a guy named Sam Salganic, who runs the Rhode Island Parent Information Network, the best place for family advocacy around healthcare in the state.
Yeah.
And I had him talking to a class at Brown. I said, Sam, you have a private audience with the Speaker of the House, the most powerful person in the Rhode Island legislature, for anything that you want. What's your first ask? And he said, we need to fix Medicaid rates for community providers. So who's he talking about? He's talking about home health aides. He's talking about the folks who provide services to people with developmental disabilities. He's talking about behavioral health. And Sam was saying those people haven't had increases in their rates in years and years and years. We're asking them to do yeoman's work, yo person's work with very difficult high needs people. And their providers, the agencies that employ them, can't give them any more money. And he said we need to pay the agencies more money so they can pay the providers more money and retain the providers and do right by the families. So what Senator De Palma is saying is we need a systematic way of doing this. What I believe, I just spoke with him briefly, is saying we need, and Medicaid, it's the Medicaid agency is really it, needs a process, a system, so that periodically we look to determine whether the rates that we're paying providers are adequate, and not take our providers, because some days, it should be without politics, because back when I was there, the word was that, the developmental disability providers run the roost. They get tons of money. Well, different regime comes in and starve them and crank them down so they don't get any raises. So what I believe he's saying is, let's just have a systematic way of doing this, because let's be clear, these rates are publicly set. This is not the magic of the market that somehow negotiate. This isn't like how Stop and Shop sets prices. This is about a public official negotiating with providers to say, I can afford to give you this much, can you live with it? And he's just trying to do that in a more systematic fashion. And it's hard, because I just said we got to pay Care New England more money. And Senator De Palma and Sam are saying we got to pay the community providers more money, and you don't want to pay more in taxes. So, this is where leadership has to happen, and this kind of public accountability around where the money's going.
Yeah, I mean, leadership is exactly the point, because, this is a devil in deep blue sea problem. When we went into the pandemic, CNAs, certified nursing assistants, taking care of people in their homes and in nursing homes, were making $10 an hour. $10 an hour, doing the hardest work there is in healthcare. It's mind-boggling, and it was because of public decisions about how we were setting their prices, essentially. On the one hand, if we go to increase, if we approach this without really deep leadership, if we go to increase what we're paying Care New England to the community providers, that's good because they will survive. but it's bad because essentially we either have to raise taxes or take money from schools or public transportation in order to pay for it. Now, it's not really a zero-sum game. What we haven't done is figure out how to create a health services delivery system that is right-sized, so we don't spend twice as much as the other industrialized countries. We spend 20 or 30% less than we're now spending, get better outcomes, and make sure that everybody's got equal access to care. We know from looking at other countries this is a doable thing, and this is where I'm not an incrementalist. I think we need to really organize ourselves and push hard to get this to happen, because otherwise we just have more of the same.
Thank you.
Hi, my name is Lim Layes, and for full disclosure, I'm president of the UNAP, which is a nurses union representing many nurses in hospitals, as well as a nurse at Fatima Hospital. So we were intricately involved in the merger process, and we had gone in favor of the merger for several different reasons, most of it being the survival of the Care New England system, Kent County, and saying that they're months away from probably bankruptcy. And if that happens, that's awful. We went through it with Westerly Hospital, we went through it up at Landmark, we came close to going through it at Fatima, and you don't want a system going into bankruptcy and then bringing in a receiver and doing all of those types of things. I agree 100% that the application was a disaster, and the more we learned, the more we realized that it was really a sham from the beginning, that they didn't give the information that they needed to, and shame on them, because they really misled a lot of people in the process. But I think we do need to do something to make sure that we make that system survive without it being for-profit. As a for-profit nurse, we don't need any more for-profits in this state. That's just not the route we need to go. But the last piece of it is when you talk about, I've been at more meetings in the last month about the healthcare system, and I've been screaming for several years now that the infrastructure is collapsing around us. And people agree that the workforce development needs to be done. All of the infrastructure pieces of healthcare are a disaster, but there's a whole lot of talk and not a whole lot of planning. And we need a planner. Everybody has their lanes. The Department of Health has their lane, the legislators have their lane, the executive branch has their lane, the hospital has their lane, and no one moves across the lanes. We really need is a healthcare czar in the state of Rhode Island who looks at workforce development, who looks at quality indicators, who looks at reimbursement rates, and makes sure that we've got someone that independently can function and get the people to merge into one lane where needed for the survival of our systems.
In these other countries where they have better outcomes and lower costs, they run a Ministry of Health process where the financing and the delivery system is in one place. Now, they don't all work perfectly by any means, but putting everybody together always made more sense to me than the chaotic process we have now.
So, Lynn, I'm not sure we remember that, but it's nice to see you.
Yes, I met you several years ago when you were the healthcare commissioner.
Thanks for identifying yourself to it. It's what makes the conversation fun. I want to, as a learning opportunity, when the health director actually has legislative authority to declare that certain hospitals are not doing sufficient volumes of procedures to maintain that service, you have the authority to shut down certain services at certain hospitals because they didn't meet a quality threshold that you have the ability to define. You know, this practice makes perfect. That's an example of an authority. It's not your full health planning czar, but it's like it's a tool you had that I maintain leaders are reluctant to use. And I'm if you don't mind, that was a hell of a hammer. Why didn't you use it? You know? Because I think this is a good lesson around.
Yeah. Well, you know, I think there were two reasons. One is that I had to rely on evidence. You know, I mean, because of the legal environment, you know, I had to be able to defend what I was going to do in court.
Right.
And for many of these procedures, when we looked at them, we just didn't have that evidence.
Yeah, but you had an instinct, and you knew where you would send your kid. I mean, there are doctors doing surgeries in places that you would not
But
refer your patients to.
instincts don't survive the health policy bar, and that was the problem.
This is our
Yeah,
challenge.
And then
Yeah.
thank you for that question, because it takes me back to the basics on how is the health system put together? And do you agree with the statement that says United States does not have a healthcare system? It has multiple systems with no coherence.
you go first.
Well, yeah, because, but so what? You know? I mean, we got what we got, and what we got is federal government paying for anyone who's over 65. We got state government with feds behind it paying for low-income people, the Medicaid program, and that's going up, that income level keeps going up. And then we've got this cockamamie employer-based system that just started in World War II because the employers couldn't give price hikes. I would say they couldn't give wage increases, so they had to find some way to attract employees in a tight labor market, so they gave them hospital coverage. And so we have all this, we got what we got. And you know, and I can wish about Medicare for all, but it's not going to happen. You know, if we can get publicly financed campaigns so that pharma and hospitals don't have a voice to Congress, then maybe we can get Lynn's healthcare czar and Michael to be able to use the leverage that he's got. But and I'll just, since you gave me the floor, I mean, we've created this dilemma. I had a budget hearing once. I like telling this story, where I was, and Health Insurance Commissioner had this paltry budget, it was nothing. But they used it as a chance to beat up people, and the first legislator said, "How come my health care is so expensive? What can you do about that?" And literally, the guy next to him says, "Yeah, and my provider says he doesn't get paid enough. What are you going to do about that?" And I wanted to say, can you guys have a conversation between the two of you, kind of square it out, and I'll just sort of let you sort it out? Because that's sort of we can't decide if healthcare is an economic engine, because Michael and I had a boss who said healthcare jobs are going to save us, meds and eds, or if it's a cost that is on the budget. And that, I don't mean to be glib, that's as a result of this non-system. You know, we're kind of, we got what we got, and so we have to make improvements based on that, you know, in the situation. We can't change Medicare here, but we can do stuff within the state.
We're now looking back, we're just moving forward. Dr. Fine?
And I think we have a market kind of system, that what drives decision-making around what we do is profit, not health outcomes. And if you think about our discussions in general are how do we pay for it, not what it is. We never sit down and say, gee whiz, we need primary care for every community of 10,000 people, and we need, you know, this number of hospitals for a state of 1 million, and this is where the hospital should be to make sure everybody has access to care, to make sure we eliminate health disparities based on race, you know, to make sure that we get the lowest infant mortality and the longest life expectancy. That's nobody's job. The only people who have, you know, people with jobs have jobs that have to do with maximizing the income of the institution that they work for, whether that institution is for profit or not for profit. You know, hospitals talk about service lines. Lynn, you know what this is like. And you know, service lines for hospitals. Hospitals are there to take care of people who are sick, who are lonely and scared when they're sick or at the end of their lives. You know, and somehow we've lost sight of all of it. So no system, not even close. We got a mess.
Any more questions from the audience?
I have one. I'm Steve Earle. I'm a healthcare IT project manager from North Kingstown. Over the years, I've worked at South County, Roger Williams, Memorial. I've worked most of my career at Lifespan. I've worked at Care New England. I've had some assignments at Eleanor Slater Hospital. And one of the things that has struck me is that we're focused, certainly from the healthcare IT side, the software side, we're focused on what do the hospitals need, and not what do the community health centers need, what do the nursing homes need, what do home health care agencies need. And the reason is like the reason that Babyface Nelson robbed banks, because that's where the money is.
Exactly.
The big software companies would go to the hospitals because they could make a lot of money there. And they were really serving their own interests as opposed to trying to improve the health care of the community. It's not unique to Rhode Island. Most of the states are in the same situation. I'm curious, are there any states in this country, and if not, are there any countries that you look at that think are doing it better than we are, that we might try to emulate some of the things they're doing to improve our healthcare leadership as a state?
Who wants to take it?
So let me start. When I was in state government, we got visited by the Ministry of Health from Northern Ireland. This was probably 2013. And they told the story of how they had gone out and bought a single electronic medical record for the entire Northern Ireland, which I think is about 1 million people, for $17 million. Right? That was 5 years after Congress authorized spending $19 billion to get people to health information systems. I can't think of another state that does it right, long and the short of it. Some have done better with shared electronic medical record interchanges. They used opt-out systems. We used an opt-in approach. Didn't work very well, still doesn't work very well as far as I can tell. But if you look, I think you have to look to other countries. Again, by comparison, I was visiting a hospital in northern Israel probably in 2004 or 5, and I was sitting in a community health, in a primary care office, and they were talking about how much they loved their electronic medical record system, because they could be sitting in their office and see what was going on with all their patients in the hospital, and the people in the hospital, when they had somebody admitted to the hospital, could look at the patient's electronic record from the community. It was one seamless record because it was one seamless healthcare system. The VA used to have a pretty good one. I think we've pretty well taken it apart now. This is where, as you said, you let profit get in the way, and all of a sudden it becomes about the profit, not about the healthcare. But you know better than anybody that the basic technology exists. We just have let ourselves get carved up and played with in the service of profit.
In terms of HIT, health information technology, no, I like Michael, I think everybody in the United States finds themselves in the same position as a result of this kind of non-system. The HIT kind of follows as a result of that, because our foundation is complicated and isn't very good. The HIT, which is, I think of it as sort of like the mortar, is pretty complicated too. I will say I'm really worried about the burden. Well, two things. I'm struck by the pandemic and how people have gotten more used to, it's been clunky, but people have gotten more used to using health information technology, kind of like they use their banks and to find information to get their lab results. And that can be very empowering, I think, really, for people to feel like, okay, I'm going to understand what's going on. I know physicians and clinical teams get tired when people come in and they've already consulted with Dr. Google, and Dr. Google's done their diagnosis. But it is, I think, a step in the right direction to have more of a partnership with the clinical team if the patient can get access to their information and know things. But I'm worried about the burden that that's creating for the clinical team, that we hear constantly about just how much work it is for the clinical team in general and physicians in particular to stay up with that. They just
Nurses get creamed.
I wasn't even thinking about inpatient settings, but the outpatient, and all done for the best of reasons to satisfy different demands, but the demands are falling on the clinical team, and that's that.
But I think the harder part on that is you have so many different systems that they don't even talk to each other. So I go to Brown University Medicine for my primary care. I get admitted to Lifespan. Brown University, whatever they're using doesn't communicate with the Lifespan system. And then I go to a coastal lab that doesn't communicate with something else.
Right.
So now you've got this whole hodgepodge that isn't talking to each other. In a state this size, God, we should be able to.
We put how
Do
much
that.
money, Chris, into an HIE?
I don't know, but I think it's
I can push back now.
right,
Because I told him he was crazy.
I was
to do
part
it.
of that vote too. But Michael raised he just said it in passing. It would be easier to get, Linda, what you were saying, if we just said, okay, everybody, your information is going to be shared. We've just decreed it this way, and maybe we'll let you opt out to kind of sign out, but we're going to make it kind of hard for you. We didn't do it that way, in part because the community told us that.
Right.
All the advocates for patient protection, particularly those related to mental health and substance use disorder, were like, no way, we got to protect that information. And so that makes life a lot more, that was how we sorted it out. I don't know that was the right decision, but it was a political process. We were trying to listen to it.
Yeah, some of us were begging the folks who were in charge of that process to change to opt out.
Yeah, and
Didn't work.
And we were,
And then when the system goes down, oh God.
Right.
See some trends in conversation on leadership and definitely primary care as that gatekeeper
Where'd I put that
to have
fax machine?
access to all that info. But I want to get into health reform, and why do you think that major changes haven't happened in health system reform despite all the pressure we get?
You can go first.
money.
This is easy.
Easy answer.
This is a business, and it's by well-intentioned people. I think the folks in any of these healthcare institutions are convinced that they're doing really important work, and they believe in the mission of their organization. But they want their organization to grow, not only to survive, but to grow, and that means they got to go out and get more money. And so it makes change very, very hard, fundamentally. And then, particularly those that are wealthy, will spend that money to protect their particular interests. Think about what goes on at the federal government around pharmacy pricing. We're the only country in the world that doesn't set pharmacy prices. And yet the pharmacy industry protects that like mad. That's what makes the point.
I think it's actually not just money. I think it's democracy and where we are as a people in terms of our sense of agency.
Okay.
So,
I'll grant you. I mean, if you want to get meta, yeah.
yeah. Well, because if you have money, you pay a lobbyist who's in Rhode Island, a former speaker. The former speaker lines up the votes, and they get what they want.
Right.
But how do we have a legislature that will permit that? How have we allowed our legislators to get manipulated by folks with money? So it's, and I understand where it comes from, but, in order to make our democracy work, we have to work at democracy. And somehow we have chosen instead to watch TV.
Yeah, I mean, campaign finance reform. I mean, if you want health reform, start with.
I disagree. I don't think campaign, that's enough. It's when, you know, in Rhode Island, if a legislator gets 3 calls about an issue, they think the world has changed. If they get 5 calls, they think it's a social movement.
Right.
Because people, you know, it costs $25,000 or $30,000 to get elected to be a state senator in Rhode Island.
I think it's more than that.
It may be 50.
Yeah.
In Texas, it's 3 million. You know, and so you can buy the legislature pretty much for a pretty low price.
Well, sorry, we don't need to get into political.
Yeah.
So part 2, is increasing public taxes the answer to allocating new money to finance reforms?
I think it's will. I think it's not about spending more money. I think the opportunity is to spend less money. I think from an economic development perspective, if we are not spending 20% less than Massachusetts, we're losing out. We've got to be competitive to bring employers here, and that's the way to do it. But that means we have to have backbone to organize a healthcare system that takes care of everybody and does it in a way that's for people, not for profit, and doesn't allow the kind of profiteering that goes on, but keeps its focus on health and health outcomes, not on profit first.
And I would say, from our vantage point, we work with other states. I'm actually pretty proud of Rhode Island. I mean, we were right out of the gate said, of course we're going to take advantage of the Affordable Care Act. Of course we're going to cover everybody, as many people as possible. There really wasn't much debate about that. And now we've got some of the most aggressive, relatively speaking, ways of overseeing our commercial insurers compared to other places. But I think, so I've thought about this. I think, and this is again philosophical, I think first you have to make a commitment that we're all in this together. And that means that we're going to cover as many people as possible. And the Affordable Care Act gave us the chance to do that. And Rhode Island said yes. And it's only when you say, okay, we're all in this together, that then you can ask your question. What would we rather do? Make the hard choices that Michael's saying of cutting the system, or raise taxes? But if we haven't made that commitment that we're all in this together, that everyone gets health insurance, it's too easy to dump it on poor people and dump it on the uninsured. And so I think if we're going to look and say the Affordable Care Act was pretty important because it said we are all in this together, and then we got to decide how much we can afford.
Okay. Any questions from the audience? Probably transition back into some hospital questions. I know both of you mentioned Eleanor Slater, Fatima. Thoughts on another Attorney General question, the conditions on the change of ownership of Roger Williams and Our Lady of Fatima. And basically the goal was to continue services. What is your opinion on that?
I don't know enough about the conditions, so I probably can't create a coherent answer.
Having an outside company basically take the financial responsibility for both hospitals to keep services going.
Yeah, I wasn't hot on the idea of an outside company, and I actually worked hard when I was in government to try to get both of those hospitals integrated into one of the other systems. You know, the political will wasn't there. And, you know, what we do with outside companies and for-profit companies is we essentially pay them to make the decisions that are maybe unpopular. So we're paying them to make decisions that we've abandoned responsibility to make for ourselves. And they profit by doing it. So shame on us for that.
Yeah, I would agree with Michael on that. I mean, Lynn, you can speak to, I can't speak to the changes at Roger Williams and Fatima as a result of this. we certainly need those beds, and we need those outpatient services from a health system standpoint. Would it have been, Michael and I both went through this issue with Landmark, where we were trying to find a home for that place, and I can't help but think that in all those instances, having local, it's like banks. That's what Michael and I were talking about with this. We're better off with local banks because they understand local conditions. And man, when you lose that civic leadership, it's hard. There's a greater sense of community responsibility at a local nonprofit health system than I think there must be when you're dealing with branch managers who are answerable to quarterly earnings and things like that. So I can't speak to patient care issues. I can't speak to population health issues. I do think in the long run, local control of those entities would be better.
Yeah, I mean, I think the Attorney General on that decision hit it out of the park as far as making sure that they committed X amount, millions of dollars into those hospitals, into those communities, so that if they upped and wanted to pull out, they had to leave their money behind. They couldn't take the money and run. But as of now, they're out looking for a buyer to take over. They've sucked all the money out of the system that they can. They've sold off their Connecticut hospital, their New Jersey hospital, their Pennsylvania hospitals. They're selling off there. So they're getting, Prospect Medical Holdings is getting out of healthcare because over the course of the last 10 years, they've sucked it dry. And now they are looking for a new buyer to come in and take over and see what they can do to pull more money out of the system.
And if you look at that process has been repeated over and over and over again around the country. Often there was a very big hospital in Philadelphia called Hahnemann Hospital, a very old, prestigious, important hospital that took care of poor and working people for many years. It basically got bought for the land it was on and put into closed down, and the land was sold off because it was near Center City, Philadelphia, and you could build condos, and they were going to make a whole bunch of money doing that. He even sold off the residency slots. It's like amazing. So.
And you're finding these hospitals now, they come in as for-profits, making all these promises of money they're gonna put into the system. Now many of them have created a non-profit branch. So for example, Landmark came in and promised Woonsocket all sorts of tax dollars, that we're gonna put money into your city as a for-profit organization. They've moved them from a for-profit back into a non-profit and no longer need to pay Woonsocket the tax monies that they promised.
And you know what happens to the money from the nonprofit? It's sent to India.
Right.
This isn't really a plug, but I hope it's not really a plug. Chris wrote the foreword to a book I've got coming out in the fall called On Medicine as Colonialism. Because this process of using the umbrella of medicine to take the resources from communities is something we've seen all across the country, and we just haven't called out for what it is. The process you're seeing with Prospect is the same process that's happened all across the country, and what frightens me is that we as a people haven't recognized it, called it out, and stood up to it.
Right. The for-profit that's coming into Kent County doesn't own that wants to come into Kent County, doesn't own a single hospital system.
Yeah.
Yeah.
We gotta give these guys some reason for hope, Michael. I don't know.
So you go first, and then I'll go.
Please, we need help.
I wanted to tackle one
Hope
more,
is a good
just
thing.
because it's another hot topic. Patient rights, physical environment, infection prevention and control were the top deficiencies that were reported in the Eleanor Slater Hospital. And I just want to know a little more about the plan you think Rhode Island needs to address those deficiencies.
Well, I think Eleanor Slater is a gem, or should be a gem, but one that has been disinvested. We basically pulled resources out of it. I think we should be investing in it. I think it could be the center of healthcare in many ways, or public healthcare, but we've gotta commit ourselves to doing it. We've gotta stand up and figure out what kind of healthcare system we want and where it ought to be, and we need to make sure that there's public oversight and investment, and then we need to invest in it adequately to function. The idea that we can privatize everything, privatize all hospital care, privatize all primary care, privatize all public health, I mean, it just doesn't work. And if you want to get a sense of that, look at the pandemic. This is what happens in a privatized world.
And I would preface by saying the job of inpatient psych care is really, really hard. and particularly Slater, as I understand it, as opposed to Zambrano. And it's particularly hard, I don't know the details in Rhode Island because of the interface between prisons and inpatient psychiatry. There's a lot of crisscross between the two, and you have, they call them forensic psych units. That means that people who come through the criminal system and end up in inpatient psychiatry for psychiatric units. And states everywhere, states are struggling with what to do with what they call their forensic psych. And I imagine that's part of the burden that we placed on Eleanor Slater. That said, I think it's easy for me to say from the outside, but a lot of this is administration. I mean, when you have Medicare saying and Medicaid saying we are going to remove the federal funding for your institution if you don't do these things, and the state has systematically ignored it. They've been unable to organize themselves to respond in repeated administrations, and that's about accountability. And Michael and I were at an event where we saw the former head of Landmark, Rick Trest, who's been willing to go. God bless him for going back in there, because it is really, really hard.
You might need a psychoval.
He's not getting any extra money doing this stuff. He's doing it because he has a sense of public duty. But
He's a good guy.
We've seen this problem coming at Eleanor Slater in particular, and with the administration, what was MHRH and is now BHDDH, and we have been, repeated governors have been unable to give it the leadership, the resources that it needs.
And repeated legislatures have been unwilling to fund it.
Yeah.
I mean, when you've been through a couple of budget hearings and all people want to work on is how to reduce spending, it's just not this is not a way to deal with human needs. You have to do public administration responsibly, for sure. But sometimes it costs more money than it did last year, and that's not because somebody has failed at their job.
Said the person who's been through a lot of budget hearings.
I think the good news on that part is the building of that brand new hospital up at Zambrano. It's in the budget, looks like it's gonna go through. And bringing all of the medical patients from Cranston to Zambrano, so you have a medical facility and then you have the psychiatric facility, so you're separating the licenses,
Right.
so you don't get into funding issues, and you can concentrate on the psychiatric component and the medical component. And I will tell you, the patients I've cared for that have come from Zambrano get the best care I have ever seen for that population.
Yeah.
They come in so well cared for with staff, and it is truly a gem that the state really needs to be proud of and work to continue to develop.
Yeah, and I'd be interested to hear from you sometime how nursing administration works inside state government, but I can tell you that medical practice inside government is a total disaster. They just haven't gotten what it takes to organize a coherent clinical system, and it's going to take some work to get them there. But that's another issue.
That's another.
Tiny little.
Any other remarks or questions from the audience? Now we get to the change, how it happens. And who is it on? Is it more on the insurance companies, legislators, all of us?
I think we have to demand and support, we, being the citizenry, have to demand and support public sector leadership. These are public problems. We can't rely on the magic of the market. You have to, I think, demand really good government, both on the executive side and the legislative side. So it gets to Michael's points about democracy. I think we've got to be willing to pay. It is crazy making. It may sound like much, but if I offered you the opportunity to run a Fortune 100 company with, what's the line that I use, with 20-year-old information technology, a board of directors of 75 crazy people,
Who appointed themselves.
and you can do it for $150,000 a year, would you do it? And you'd say, no. $150,000 sounds like a lot of money, but not for those headaches. And that's the job of a Medicaid director. We're asking the Medicaid directors to run what amounts to 1/3 of our budget. We're paying them $150,000. They are now, I'll name names, they are contracting with Neighborhood Health Plan, and that CEO makes, I don't know, $300,000-$400,000 2 or 3 times, so they can take orders from the Medicaid director. It's completely backwards. And so we have to, if you want public sector leadership, even if we don't even get to a healthcare czar, we gotta be willing to pay for it. And it turns out that the places with the most competent executive branches are actually moderate Republican governments. Places like Tennessee and Arizona that will redesign their civil service so they can actually get people to come and stay in health service, stay in the executive branch for a while, because they're willing to pay more competitive wages, get them to stay in there. And then there's something on the legislative side, where we've got to, if the legislators don't want us to do policy, then they've got to take that responsibility themselves, and they can't, do what Michael's saying. 3 calls is a crisis, and 5 calls is a law. There's a lot we can do.
Yeah, I think it's one step, I think Chris is right, but it's one step beyond demanding public accountability. I think the bad news is that this is going to take a social movement, like the civil rights movement, or the movement for marriage equality, or the anti-war movement, to change it, because there's so much resistance to change. And that, I hate saying that, because it's so much work, and it takes such a long time. The problem is, it's sometimes called the Yiddish modus ponens. If not this, then what else? There's just no other way to get there. And so the bad news is it's a big hassle, but the good news is that if you look at American history and who we are as a nation, we started as a group of, like Southern white guys, mostly farmers, who wanted to take care of each other, and they figured the best way to do that was to keep things pretty equal. And then this equality thing sort of worked between them, and so other people wanted it. And the history of the United States, and this is where my hope is that every 20 or 30 years we have one of these social movements. The abolitionist movement, the movement for women's suffrage, the labor union movement, the anti-war movement, etc. And as we have a social movement and many people get involved with making the change, that turns out to be democracy itself. And that reignites our democracy, and that has made this nation, that plus immigration, has made this nation the vital place that it is. So, I don't want to think about the work it takes, but I can't figure out another way to do it, and it gives me hope that we've done it before. Since we've done it before, I think we can do it again.
Great. Does the audience have any thoughts on how we can make change?
I'm already exhausted thinking about
I get it, it's tough. This was a very informative conversation. conversation. Sue?
Oh, I was just wondering, I read started to read Dr. Fine's book on healthcare revolt. And it seemed, I think, the first chapter, and you were talking about, how to get there. And I was thinking, we have climate goals. Why can't we have healthcare goals? Why can't we say we want less babies to die, less mothers to, suffer serious consequences, and fewer people to have diabetes? Why can't we have these incremental goals, and when we get there, then move on to the next?
It's called Healthy People. I think we're up to Healthy People 2020 and Healthy People 2030.
We already have.
People in public health have been setting these goals for the last 30 years. The challenge is not just setting the goals, but getting the work done. The challenge is to stop admiring the problem and start changing ourselves.
And we know how to do that. But it is hard work. You think about how public attitudes have changed around smoking. That's a real victory. Think about how public attitudes have changed around what constitutes marriage and marriage equality. So, what are the goals that we can target that will rally around that? I think we've had some around COVID. We've actually, and again, this is where if you think it's tough here, it's really tough in some other states. So, our people like Elizabeth Michael know our COVID response here, all things considered, I'm proud of it. I'm proud of the work you guys do, and I can't say that in some other states. I know public health officials and I know the guy in Mississippi. Man, it is tough to do the work there. What the amount of resistance that they face, right? So we gotta pick goals that we can rally around. And one of the real challenges for us, and we've seen it with COVID, is this notion of personal responsibility. That we can make progress on smoking when we could find an outside enemy that was the manufacturers who took the pledge. We can't do that around obesity because we're stuck on this notion that somehow I'm obese because it's my fault, that I don't exercise, I don't eat right. We don't understand genetics, we don't understand the built environment and stuff like that. So we've got to pick, I guess I'm just saying, we've got to pick goals that get us to rally together and not use individual responsibility as kind of a cop-out. Well, you make your own choice and you have to live with the consequences. Because health is if we've learned anything in COVID, health is a collective effort. We can literally make one another sick.
We say thank you to the library for doing this. Yes. And thank you to Elizabeth for being an amazing librarian.
Thank you to you folks for coming out.
Yes.
Democracy lives, citizenship.
Dr. Fine, Dr. Koller, very realistic conversation, informative. So thank you Pawtucket Library for hosting the event, and the awesome audience for being interactive and giving your opinions. We definitely appreciate all the perspectives. So look forward to the next conversation. So thank you all, and be well.
Thank you.